years ago, and his wife introduced me to the best squash soup I've ever had. And I never had squash soup before, but now I have it all the time thanks to Dileep. So I'm not sure how good he is at epilepsy, but they're really good at squash soup.
Well, perfect. You know, this is always the best way to be introduced, because my wife is much better person than I am as it relates to this as well in general. Thank you, Glenn, for invitation. All right, so we had a lot to talk about today. Let's just see if we can cover as much as we can. I seem not to have control of my slides. All right, perfect. Let me go back. All right, well, I'm just going to start here. So this is I'm going to have a couple of things I want to talk about. I want to try and talk to you about some basics of EEG. We'll move over to talking about some normal EEG and normal variants. We'll try to talk some about interictal EEGs, and then if we get time, we'll talk about EEG seizures. So EEG is a way of measuring brain waves, first discovered by Hans Berger in 1929. Electrodes are placed over the head regions. They're placed in a specific order called the 10-20 system. The 10-20 system takes into account certain anatomical landmarks, the preauricular points left and right, the Nasion and the Inian. Then 10 to 20% measures between those two distances are where these electrodes are placed, therefore called the 10-20 system. Anatomically, these electrodes are named based on the site of where these electrodes are placed. So it's FP if it's frontopolar, F if it's frontal, T if it's temporal, P if it's parietal, O if it's occipital. The numbers that are following these electrode that are in the electrode names are referencing how far away they are from the midline. So if they are closer to the midline, there are smaller numbers like 1 or 3. If they're further away, the numbers are larger, so 7 and 8. If the numbers are even, they are on the right side of the brain. If there are odd numbers, they are on the left side of the brain. So these are standard electrode placements for EEG placements. So I'm not getting control. Here we go. Perfect. Okay. So next, generators of the EEG signals. What is the generator of EEG? It is not action potentials. Action potentials are too short in duration and involve too small of regions of the brain to be recorded by an electrode sitting on the skull. What is beautifully capable of generating an EEG is the postsynaptic potentials often seen in the layers 2 and 3, which are the dendritic structures of our 6-layered cortex. Layers 2 and 3 are where these synaptic potentials are being generated at the dendrites, and they are the generators for the EEG. When you have enough brain tissue activated, so you have to have a certain amount of brain tissue, somewhere between 6 to 10 centimeters of cortex to be activated for it to be seen by the scalp electrode. Okay, so it's the postsynaptic potentials, either excitatory or inhibitory, and these generators create what we call a dipole. I don't think I have. Oh, yeah, okay. Anyway, on the slide you can see at layer 2 and 3 in the first example, the first section. You can see that there's activation in the first set of the slide. It doesn't move. I'm moving the mouse and it doesn't move. That's okay. Now, okay, here we go. So anyway, you can see here in this first example, axons coming from the thalamus activating at layer 4. Okay, so it's creating a current sink at layer 4. What happens then is a positivity at the apical dendrites. That positivity is what creates the current, the current source, the continuous current sink and the current source. So negativity is the activation of the potentials at layer 4, and positivities there are occurring at the dendritic apical structure. That's in that one example where the thalamus is what's creating the excitatory potential. Most of EEG that we see are from interneurons. One region, one pyramidal cell activating another pyramidal cell, and that situation occurs where in the second example, where you see the axons from the adjacent or contralateral brain, activating the layers 2 and 3. Current sink there becomes a negativity at layers 2 and 3, and it creates a downward pen deflection. You can see that on the slide there. So that downward pen deflection is created by that negative source at layers 3 and 4, and is best seen when this is in a vertical structure, vertical organization. In a vertically organized dipole, the scalp EEG beautifully sees the structure, sees the activation. When it's tangentially oriented, such as within a sulcus, the EEG electrode has a much harder time seeing the source. All right, mechanisms of interictal epileptiform activity. Here in this slide, rather complicated, but here is the first section that is showing you the discharge of what we see on the scalp. So this scalp EEG is seeing a large negative deflection here. That's generated by in the cells themselves. So an electrode placed in the cells shows an excitatory postsynaptic potential. And here are the series of firings of action potentials, too short to be seen on the EEG, but they occur during the AMPA activation on a glutamate receptor. Following that, surround inhibition occurs, so GABA activation occurs, and so potassium ions flow out, creating an aftergoing hyperpolarization within the cell, and that generates the slow wave that we see on the scalp. So an epileptiform activity is generated by large amounts of tissue undergoing what's called a paroxysmal depolarizing shift. This is actually just an accentuation of the normal situation within a cell, where the cell becomes excited and then becomes inhibited by surround inhibition, either by feed forward and feed back inhibition. When it's exaggerated and hyperactive, excitatory across multiple regions of the brain, that is what is the sine qua non of epileptic discharges. Various band frequencies can be seen in the EEG. Beta frequencies are within the 12 to 30 hertz frequency. Alpha frequencies are within 8 to 12 hertz. Theta frequencies are from 4 to 8 hertz, and delta is from 1 to 4. Now, these are frequencies, very different than rhythms. So when I say alpha rhythm, I'm specifically talking about an alpha frequency seen in the posterior head regions. Alpha frequencies was first discovered by Hans Berger, and he named them in series of order of discovery. Beta frequencies are typically seen in the frontocentral regions in the normal patient. Theta and delta frequencies are often seen in sleep. Next, we'll talk a little bit about montages. How do you display an EEG or a picture of an EEG? It's dependent upon you. You can choose. There are two main types of montages that we use. Either a bipolar montage, where the electrodes are right adjacent to one another, or a referential montage, where the second electrode is held constant. In a bipolar montage, you can go longitudinally, such as this situation, where you take the first channel, and you take the first channel representative of FP1 in a comparison to F7. It's a mathematical subtraction. So you take information of what's seen in FP1, subtract it from what is seen in the second electrode, F7, and that gives you the result. The amplifier amplifies the activity so you can see it better, but that's simply how the EEG has been displayed. So bipolar montages are comparing adjacent electrodes. In the transverse montage, the electrodes go front to back, so giving you what essentially is a sagittal view of the brain, going from the side. It's beautiful to compare right and left hemispheres because there's nice symmetry here. The first chain of electrodes are going from the FP1 electrode to O1, so that's the left temporal chain. The next chain of electrodes is often FP2 to O2, the right temporal chain. So here we have homologous regions of the brain being compared, and you can look at that as a way to distinguish sides and how equal it is from homologous regions, the activity. Transverse montage goes from left to right. And from left to right is a great way to see midline activity. So what's in the center of the screen is midline activity of the brain. It's great for things like sleep, where we see a lot of midline activity. Does not have symmetry here, though. So one chain of electrode is not symmetric in terms of one structure, one region of the brain to the next. It's giving you sort of information from front to back, but the chains themselves are not symmetric when you compare one chain to the next. here's some examples. I'm going to give you a series of slides that all show the same thing. Here's a sharp wave. This is an example of an epileptiform activity where it's an outstanding discharge. It outstands from the background. The discharge is very high in its amplitude in comparison to background activities. It's followed by a slow wave. This is a longitudinal bipolar montage. So this is left temporal chain, right temporal chain, left central chain, right central chain. And when you have Z as the second designation, it means that it's in the midline. So FZ, PZ, FC, CZ, and PZ are all midline electrodes. This is the typical double banana montage that we see in North America. In Europe, they start with the right and then compare it to the left. That's the only difference typically. In this temporal chain, this double banana montage, it gives you really nice information about temporal activity. So here is what we call a negative phase reversal. That means the phase, the deflection of the pen is going down here, down again here, but then it goes up. So the phase reverses. It reverses from down to up, and the point of reversal is where the maximum negativity is occurring. And so in this situation, it's at T7. T7 is the shared electrode across the two phases, two changes of phase. And it's a nice, beautiful way for your eye to pick up the point of maximum negativity, okay? So if we compare that same page, though, in a transverse montage, it becomes a lot more complicated to figure out where the maximum negativity is. Again, midline activity, very nice and easy to see. It's quite here. It's seen nicely, beautifully here in the middle of the screen. But the maximum deflection here is actually at T7, which is at the end of the chain. So your eye has a harder time to pick up where the maximum is, and it's to calculate that F7 is the next most maximum involves some math in order to interpret that. So hard to see in a transverse montage information on the temporal chain, much easier to see information in the midline. In referential montages, in contrast to bipolar, electrodes in grid 2, or the second electrode, is always constant. So for example, in this example here, the second channel, grid 2, is always CZ. So what you're doing here is you're comparing grid 1 to grid 2. Take this analogy as a way to understand montages. Say you're in a pond and you want to see you drop a pebble, and this pebble is, let's say it's an epileptiform activity, and the pebble drops into the pond. It creates a series of deflections. Where the deflection is maximum is where the pebble was dropped. And the series of ripples that occur afterwards has lower and lower maximums across as you go further and further away from from where the pebble was dropped. In a bipolar montage, if you want to localize where this deflection is happening, you would just put one electrode to the next and compare its phase. And the point in which the phase reverses, that's the location of where the maximum deflection was, or where the pebble was dropped. If you want to understand the amplitude, or how high these waves are, how do you do that? Where you put a whole bunch of electrodes over the entirety of this pebble where it's dropped, and you compare it to an electrode that's distant away, not even seeing any of these waves. So that second electrode, which is held constant, would be measuring the background quiet activity. And so grid 1, whichever electrode grid 1 that shows the maximum deflection, is where the pin was, where the pebble was dropped. And it's a beautiful way to really calculate precisely how high the deflection is, because in grid 2, it's not giving rise to any of that information. It has zero impact on the deflection. Okay, so referential montage, great way to interpret amplitudes. It has to be not involved in the activity, because if it is involved, it will cause a phase reversal and it will confuse you. So and as long as there is no phase reversal, the area of maximum pen deflection is where it's the maximum. There's another type of montage one can use, which is called a common average montage. Having problems here with. No, it's not. Okay. So the common average montage is a way in which you can compare. The second electrode is a mathematical sum of all the electrodes that are present and average and divided by that number. So say you had 25 electrodes and you wanted to get a common average montage. You take all the information that 25 electrodes divided by 25. So that average electrode will give you a smearing effect. It prevents having one electrode over valuing or having more impact on that second electrode number. Now, that's okay as long as all the electrodes are rather quiet. If you have one electrode that's very high in terms of its amplitude, that electrode will have more representation for its effect on that average. So in many instances, the frontopolar electrodes are subtracted from the average because the frontopolar electrodes can have a lot of artifacts such as eye blinks and can contribute to an average. So it's another way to use an average montage. Let's talk a little bit about pen deflections here. So how do you understand what each electrode is doing? Well, first, if you know that in this situation that there's an upward deflection happening here, I will call it a pen deflection just from historical perspective. The analog machine had a pen, and anytime it would deflect upward, what that would mean is, think of it as a graph. So you have a graph, positive numbers are on the top, negative numbers are on the bottom, 0 is in the middle, okay? So let's say that you have a upward deflection. That must occur if the first electrode is more negative than the second electrode. So if T7 is negative and P7 is positive, that if you draw a line between those two, it creates an upward deflection. So what causes an upward deflection? One of two conditions. That is what we don't know. We do not know the polarity of the event, but let's assume that the polarity of this event was negative, okay, that generated this upward deflection. You have to make an assumption. The assumption is that the polarity of the event is negative. If it's negative, which electrode is seeing this event? Is it the first electrode or the second electrode? Is it T7 or P7? Which one's more negative? T7. So T7 is more negative, and therefore, if it's a negative potential event, T7 is where this activity is occurring. Now, if I told you that the event was created by a positive polarity, which electrode is seeing this event then? P7, because P7 is positive. That's right. Okay? So you have to make an assumption. Now, our lives are made simpler by the fact that the vast majority of epileptiform activity in the brain is a negative polarity event. You remember the slide that we talked about a few moments ago, where layers 2 and 3, interneurons are creating a negative sync at layers 2 and 3. That's how a negative epileptic activity is occurring. Most of the time, epileptic activity is a negative polarity event. Therefore, if you see a negativity where it's maximum, that is where the epileptiform activity is situated. Now, let's take the opposite situation where the pen deflects downwards. What creates that? Well, let's go back to the graph again. If grid 1 is positive compared to grid 2, then the line goes down. Therefore, a positive electrode in grid 1 and a negative electrode in grid 2 will create a downward deflection. Okay? Now, let's see how we can localize this more simply. Well, even in bipolar montage, it's easy. If you have a situation of what we call a phase reversal, meaning the phase reverse from down to up, the point where that event occurs at T7 is where the maximum negativity is. So you don't have to do this complicated sort of pen deflections, math, and etc. to understand this. You just look for a negative phase reversal in a bipolar montage. So when you see that negative phase reversal, well, let's take it step by step. Let's see if we're right here. So the pen is deflecting down here. So let's go back to the graph. If it's deflecting down, F7 must be more positive than T7. That makes sense. So T7 is negative. Now it's deflecting up. Well, then T7 must be more negative than P7. That's deflecting up. So yes, what's always negative? T7. So this negative phase reversal makes sense for a way for us to localize. Now you can do some. You can see this here in the in this more. I have more number of channels here. It's going down in the first channel. It's still going down in the second channel. It's going up here. So then that phase reversal is occurring at T7, and therefore, a quick look at this. You don't even have to do the math per se. You can just say, oh yeah, the maximum is at T7. Now, if you have no phase reversal in a bipolar montage, so there's no phase reversal, here's this deflection where there's only an upward deflection, The rules state that the maximum negativity or positivity are at the ends of the chain. Again, we have to make an assumption of knowing what the polarity is. If I tell you the polarity is negative, the maximum here is FP2. It's at the end of the chain. If I told you that the polarity of the event was positive, then it would be O2. Okay? You have to know what the polarity is. And in most situations in epilepsy, the negative polarity event is usually seen in patients with epilepsy. All right, so let's move over to rules of localization using a referential montage. Much more simpler. As long as the reference is not involved, and there is no phase reversal, then the area of the electrode that shows the maximum deflection is where the maximum is. Okay, the maximum electrode has the maximum amplitude, as long as the reference is not involved. If the reference is contaminated or it's involved, then you will have a phase reversal in a referential montage, and you cannot necessarily use that as the information for maximum negativity. You can do some more fancy information for those of you who are EEGers and epilepsy specialists. You can put a line right down at the point of maximum, and in this situation, you can see that the maximum negativity is at this point, but then a few milliseconds later, about 20 milliseconds later, there's a second negativity. And here this is showing evidence of propagation. Yes, it's still maximum at T7, but 25 milliseconds later, the activity moves to F7. So that's a way to understand how epileptic activity moves over a serious period of time. And you can see this much more clearly in subdural or depth electrode recordings. So voltage maps are basically what we were talking about before, where you take a maximum point of positivity, and then you draw areas of sequential regions that are less maximum, and it gives us a nice way of understanding the pen deflections. All right, here we go. And here's just and sometimes this can be done by the computer by just putting a line on the point of deflection, and it gives rise to this pen deflection here. Okay, some normal EEGs. Here's an awake EEG that shows normal alpha rhythm. The alpha rhythm different from alpha frequency. Alpha rhythm is a posteriorly distributed alpha frequency that's maximum in the occipital, parietal, and posterior temporal regions. It waxes and wanes. It will be attenuated by eye opening, activated by eye closure. In younger individuals, it can be you can often see some slow waves associated with the alpha frequency. Here's a sleep montage. Notice it's a transverse montage going from left to right, F7, F3, FZ, F4 to F8. That's going across the brain. But it's giving us beautiful information about the midline. See, in the center of our EEG, we have a series of what's called vertex waves. That's V waves that are occurring during sleep in stage 1 and stage 2. They're seen at maximums. Sometimes it can be seen in runs. In younger kids, it can be seen. It can be sharply contoured, and sometimes be mistaken as epileptiform activity. So be aware of that. Immediately after this is a K complex, and that is a very large, high amplitude frontocentral delta activity that is superimposed on spindles. And that is also evidence for stage 2 sleep. Here's another example of spindle activity. Spindle activity occurs within the alpha frequency, and it is it's seen also maximum in the midline. It's evidence of stage 2 sleep. Post or posterior occipital sleep transients are findings seen in stage 1 sleep. These are positive transients that are seen in the occiput, and they can also be seen in runs. You can see them here. They're seen symmetrically, both in the left and the right occipital regions, and it can be seen in stage 1 and stage 2 sleep, but less commonly in slow wave sleep. And here I've remontaged that same discharge in an A1 reference, A1, A2 reference, and you can see how O1 is positive. It's a downward deflection in a reference, so down. So if pen is deflecting downward, O1 is more positive than the second electrode, which is A1, and showing evidence that this is basically consistent with a positive polarity event. Here's that example of posterior slow waves of youth we were talking about before. This is a slow wave that is overriding the alpha frequency. It shares a lot of the same characteristics as alpha. It will attenuate with eye opening. It's seen usually in less than 21 years of age. It should not be classified as an abnormal slowing. So here's some provocation methods by which epileptiform activity can be provoked. Hyperventilation is a way to provoke epileptic activity, particularly 3 Hz spike and wave or in patients with absence epilepsy. What happens with hyperventilation is you're blowing out off CO2. It causes a relative vasoconstriction of the brain. Slowing is a common feature that we see in hyperventilation in the normal patient. Slowing can last up to 2 minutes after hyperventilation ends. Sometimes abnormal slow or focal slow can be accentuated by hyperventilation. Hyperventilation should not be done in patients with pre-existing cerebrovascular disease such as stroke, hemorrhage, and sickle cell anemia. These are times where actually you can accentuate the vascular pathology by hyperventilation. And it's only helpful in patients with generalized epilepsy. It does not tend to accentuate focal epileptiform discharges. Here's another provocation method by which you can accentuate generalized epilepsy, something called photic driving. We're flashing bright light at various different frequencies. Here is a frequency of 20 Hertz. In this situation, I'm showing you normal finding of what's called photic driving, where the alpha rhythm is driven by the frequency. That is not abnormal. That's absolutely normal. If this photic stimulation, though, induces a series of epileptiform, high amplitude frontally maximum or occipitally maximum epileptiform activity that outlasts the stimulus, meaning it persists after the stimulus is terminated, that is seen in generalized epilepsy, particularly a type of epilepsy called juvenile myoclonic epilepsy. Here are some normal variants not to be confused with epilepsy. This is called phantom spike and wave, and this example is what's called the fold version of phantom spike and wave. It's commonly seen in females, that's F, commonly seen in the occipital leads, that's O, usually low amplitude, that's L, and often seen in drowsiness. You can see how low amplitude this spike is. They're often between 5 to 7 Hertz, often called, this phantom spike and wave has often been termed also 6 Hertz spike and wave. And this is a normal variant. Do not confuse this with generalized epilepsy. Here's that same 6 Hertz spike and wave with another type of morphology called WAM, seen in wakefulness. It's seen in adult, usually males. It's seen with relatively high voltages, comparison to the fold variety, and also occurs around 6 Hertz. Okay, so this is just another variation of the same phantom spike and waves, more commonly seen in males. This is the most common normal variant that is misinterpreted as a epileptiform activity. It's called wickets. Wickets can occur in the mid-temporal regions of the brain. They are distinguished from epileptiform activity in that they often occur in trains. And there is no aftergoing slow wave associated with this. Okay, so do not confuse this as epileptiform activities. It's one of the most common misdiagnoses made on EEG. Often seen in drowsiness, can be seen in wakefulness too. And in sleep, later stages of sleep, they can occur in isolation too, but again, low in terms of voltage, low to mid voltage. They're not very high voltage. They do disrupt the background, but they're not that high in comparison to a sharp wave. Again, no aftergoing slow wave. Here's another example of a wicket. You can see how they occur in that series of runs. It's like a train of transients that we see. Again, no aftergoing slow. Here's another normal variant called a rhythmic mid-temporal theta of discharge of drowsiness, or RMTD. It has typically a notched appearance, again mid-temporal in its distribution. It can have left and right activation, sometimes synchronously. They tend to undulate. There's no alteration in behavior with this. In the past, these were misinterpreted as seizures. get stuck again. There we go, artifacts. Okay, here's an example of what we call an electrode pop. This is a non-physiologic artifact. You can see at C3 a very steep upward deflection followed by a slower downward deflection. Only at one electrode, has absolutely no field around it. This is very characteristic of an artifact of an electrode is loosely adherent to the scalp, and if the technician comes and reapplies the gel, that artifact will go away. Let's see. All right. Glossokinetic artifact. This is an artifact that's caused by the tip of the tongue. The tip of the tongue has a dipole, and it's negative at the tip and positive at the base. So if you move your tongue while you talk, it can create a series of deflections that can look like slowing. And it's absolutely normal. It can be distinguished by having the technicians asking the patients to say la, 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 and that will cause that artifact to appear. Also associated with this is EMG or myogenic artifact. Another type of common artifact we talk about is the eye movement artifact, which we see here as well displayed. These are the front of the eye, the cornea is positive, so when you close your eyes roll up, something called Bell's phenomenon, and it causes a very prominent activation at the FP1, FP2 electrodes. And because it's positive, the pen deflects downwards, okay? FP1 is more positive than F7. It creates a downward deflection. Okay, here's an example of 60 hertz where I put a line artifact. This is the line artifact that occurs across any electrical device or the bed or cell phone charger. As soon as I put a 60 hertz filter, the artifact goes away. You can see it diminish at least. And so that's something to recognize. In the 60 hertz filter, it's a notched filter that takes away specifically artifact or any sort of information at 60 hertz. In Europe, it's 50 hertz, but in the US, it's 60 hertz. Here's another example of an eye movement associated artifact called the lateral rectus artifact by moving the eyes side to side. The lateral rectus causes an EMG spicule. Notice how this is very, very tiny. It is not that it is not larger than 80 milliseconds. Remember I told you a spike is 80 milliseconds? I don't remember I said, maybe it was the other one. A spike is 80 milliseconds, somewhere between 80 millisecond duration. Sharp wave is between 80 to 120 millisecond duration. This is much shorter than that, and it's very, very tiny and seen in the FP7 and F7 and F8 electrodes, where the lateral rectus is best visualized. So moving on to some interictal EEG, if you look at this, you can see that there is a subtle slowing, delta range slowing in the right temporal region. And that's a continuous slow, meaning it's present pervasively through this EEG recording. That's indicative of a structural lesion in that area. In this situation, we see that the beta frequencies are much higher and more accentuated in the left central regions compared to the right central regions. And that's in a situation where the patient has had a skull defect. And because the skull has been removed, the brain activity is much more easily visible from those electrodes. Here's a patient who's in coma and is showing continuous slow within the delta frequency in a patient who is unresponsive and comatose. Here we have a patient who has both a subtle amount of continuous slowing, but also in addition to that, some slowing within the right temporal region. So in this patient, we call this continuous slow, generalized and lateralized to the right temporal region. In this patient, it would be consistent with an encephalopathy as well as a possible cortical dysfunction in the right temporal region, such as a lesion of one sort or another. In this patient, we see not only the continuous slow of the recording, so there's a lot of delta and theta slowing, but we see a very pervasive periodic pattern occurring a little bit faster than 1 hertz. And this periodic pattern has a maximum that is in the frontal and temporal chains, and it's consistent in a patient with metabolic encephalopathy. Various types of metabolic encephalopathies can induce periodic patterns. Yeah. Okay. Here's that. Here's a discharge that's called a periodic lateralized epileptiform discharge. In this situation, we're seeing slow waves or maybe theta waves that are maximum, that disrupt the background, that are seen lateralized to the right hemisphere. And this is a situation in a patient who has an acute structural lesion associated with epileptogenicity in that lesion. So such as a stroke, viral encephalitis. It's commonly seen in patients who have very intractable epilepsies, maybe in a patient who's just recovered from status epilepticus, where you have a periodic pattern that remains in that left, in this situation, the right temporal chain, and often refractory to medications. So something important to recognize and impacts treatment and surveillance. Here again is an example of a sharp wave. You've seen a series of these now. In this situation, the phase reversal that we're seeing across this bipolar montage is maximum at F8. So this is a right frontotemporal discharge. Notice the nice aftergoing slow wave. Notice how high amplitude this is. This is a 75 microvolt recording. So very high amplitude discharge really disrupts the background and it has an aftergoing slow wave. Sometimes, oops, sorry, going in the wrong direction. Perfect. Thank you, Glenn. Yes. So here is an example where you see repetitive sharp waves. The sharp wave is seen not only once here at T7 maximum, again that phase reversal really helps us localize, but then you see it repeat in the latter parts of the EEG. If you see this pervasively and persistently, it may be seen sometimes in patients with vocal cortical dysplasia. Now the roller stopped working too. All right, here's an example of polyspikes. This is a situation where there is a series of spikes that occur in a patient with generalized epilepsy. Here's another situation of spike and wave. Spike and wave. So not only do we see a spike, there's a wave afterwards. They occur at a fast frequency here, that's faster than 3 hertz. And it's also still indicative of a patient with generalized genetic epilepsy. All right, we're going to finish with an EEG seizure. So this is a definition of an EEG seizure, something that evolves both in time, space, distribution, and frequency. Okay, time, space, distribution, and frequency. So the first page of this EEG seizure shows you a series of repetitive sharp waves, somewhere occurring at a frequency of a theta delta frequency. In the next page, all of a sudden that transforms into a different frequency. This frequency is now within the alpha range, and that is seen nicely at F7 in the temporal chains as well as the frontotemporal chains on the left side. In the next page, the EEG evolves. Let's see here, evolves in space. Okay, time, space, frequency, and so you're seeing it evolve into the central regions, and often associated with some behavioral manifestation changes. Okay, so these are definitions, and here at this point the EEG seizure ends. And with that, I will stop and take any questions.
So Craig, we're going to do the audience response questions with the group.
Awesome. Okay.
Thanks, Dileep. While we're waiting for the slowpokes in the other area to join us, if somebody has a question, we could take one to start. I felt like I was starting to get nervous. I felt like I was back in residency. And am I on call tonight?
You could be.
As long as I'm not doing an epilepsy call, I'll be okay with that. But anybody have a question they'd like to ask while we're just waiting for people to come in?
Right. Yeah. So burst suppression.
So the first question was about
it's about
spikes.
Spikes. How do you define
and then
spikes?
about someone with a status epilepticus and then burst suppression and
Right.
different waveforms, I think.
Yeah. So spikes are defined by both a disruption of their the background activity. First, it must disrupt the background activity. It must be of medium to high voltage, and then there should be an aftergoing slow. Spikes have a duration. The sharp component has a duration of about 80 milliseconds. 80 milliseconds. Sharp waves has a duration of about 80 to 120 milliseconds. Your question relating to status and burst suppression is a little bit more difficult. If you see a patient who's in status and the status has been terminated, typically with intravenous anesthetics, and they go into a burst suppression, that's typically thought of as at least disrupting the motor components of the status. That's typically what we see. Now, as you lighten up the anesthesia, the patient may come back with EEG evidence for persistent status. So the notion clinically of how you manage this is to leave the person in burst suppression for some period of time, and then lighten up the anesthesia to see if the status has resolved, and they go back into a normal state. So it's a lot of it's usually at the bedside and clinical in terms of burst suppression. Now, burst suppression by itself is easy to define. There's a period of suppression of the EEG less than 20 microvolts, 10 microvolts, followed by a series of bursts. If they're associated with myoclonus, these bursts are associated with myoclonus, the worry is that the status is still persisting. So each burst results in myoclonus, and it's typically seen in an anoxic ischemic event. But yeah, so a lot of it's clinical, yeah. What, I'm sorry? Laplacian montage. So no, we did not discuss the Laplacian montage. A Laplacian montage is when you take the second electrode, the referential electrode, and you use the local electrodes around it, summit, and it provides more of kind of a localized version of a common average montage. So it's taking, so if you're taking FP7, you take the surrounding electrodes, F7 plus the surrounding electrodes, summit divided by the number of electrodes that you're recording from, and you use that as your grid 2 electrode. And the thought is the Laplacian montage can give you information in locality as a reference. The local regions serve as your referential source. It has its own problems, particularly related to things like sharp waves. When you're within the sharp wave, it can attenuate the amplitude, but it can give you more kind of a localization of that amplitude where the peak is maximum. Yeah. Mm-hmm. Right. Yeah,
So again, if you have a question, please come to the microphone to ask it. Otherwise, we're going to have to repeat all the questions.
Yeah. So the question was, what do you use to consider the treatment of PLEDs, and how aggressively should you treat them? And that's a very controversial question in the past. I think at this present time, the things I can say is that, first of all, those patients should be watched very closely on continuous EEG, number one. Those patients should be treated adequately with anti-seizure medications. How aggressive you treat them is a little bit variable from person to person, depending upon the clinical situation at hand. Typically, these patients require multiple anti-seizure medications. Whether or not to put these patients in anesthetic coma, it typically relates to the clinical scenario that the patient is in. If they came in convulsive status epilepticus, typically these patients will be transitioned to complete burst suppression until there's a period of time where they can acquiesce from that status and then lighten up again. In a patient who has, for instance, epilepsia partialis continua, where they can have PLEDs, that's a completely different situation, and you may treat them still aggressively with anti-seizure medications, but maybe not into intravenous anesthesia.
All right, Dr. Siddiqui, a couple questions. One was, and I'm sure no easy answer here, treatment for PSP. Any options?
So we know that there's no cure for PSP, so there's no cure for any of the typical or atypical Parkinsonian disorders. However, you can always try to treat symptomatically. Somebody has Parkinsonism, you can give them levodopa, you can try amantadine. Of course, occupational therapy, physical therapy, speech therapy is extremely important. People have dysphagia, you can think of a feeding tube for those things.
Yeah, so unfortunately, it's really symptomatic. And then another question was, if someone's on Cinemet and it becomes less effective, does it become less effective over time because some type of internal desensitization, or is it just progression of the disease?
Yeah, so that's an important question and very commonly asked even by the patients. And one of the reservations that patients have in starting a medication like that, because it's gonna lose effectivity. So the way I answer that question is it is a combination of the disease progression and the medication. So because as with advancing disease, the brain loses its ability not only to produce dopamine, but also to buffer dopamine. So if you're taking medication as an outside medication, in the beginning the brain buffers the levodopa, so you don't have the peaks and troughs that you see. So it releases it, catches it and releases it gradually. But as the disease progresses, you lose that ability. So whatever you take is whatever you have. So it peaks in quickly and leaves the brain quickly. So you have these peaks and troughs, and then the timing between those becomes wider. So it's not the medication itself becomes ineffective, it's actually the duration of the medication. It becomes more complicated to manage those things. And you can adjust that by either taking the medication more closer together 4 times a day, or adding an extender like a COMT inhibitor with each dose, and that helps the medication last longer.
And they must be having trouble out there with PSP, because the other question was any biomarkers or just clinical?
So there's research going on, but there's no biological marker commercially available. We're looking for tau protein in the CSF, and I sort of asked that question yesterday as well, but it's not commercially available yet.
Okay. Yes.
Do you have patients presenting with lightheadedness with Parkinsonism?
Yes, all the time, because one of the causes of Parkinsonism is, Parkinson disease, DLB, as well as MSA. These conditions are synucleinopathies, and that can cause orthostatic hypotension. So lightheadedness is very common in these patients.
What would the patient present with? Dizziness? Or?
So dizziness is you have to, so the way I approach dizziness in general and in patients with Parkinsonism is, can you please describe what you feel? Is it like a spinning sensation? But if it's an orthostatic symptom, they usually say, oh, lightheadedness, about to pass out, graying out, or in people who have significant neurogenic orthostatic hypotension like MSA, they can have like a coat hanger sign that, because that's from hypotension leading to muscle ischemia, causing muscle pain in the neck and upper shoulder. So you have to look for those things as well to find out what the etiology is. Of course, measuring the blood pressure in the clinic is extremely important. I ask my staff to measure for orthostatic hypotension in each patient. And the way I remember this is 30, 15, and 3. So there has to be a 30 millimeters of mercury drop in systolic blood pressure, a 15 millimeter drop in diastolic pressure over 3 minutes of standing.
Okay. Thank you.
Can I pick on Dr. Sneaky one more time?
Yep, please do.
I was curious as to how helpful do you think DAT scans are with atypical Parkinsonism, or what is your approach to the utilization of a DAT scan if you think the patient has an atypical Parkinsonian disorder?
That's a very good question. So DAT scans have recently been, like in the last decade or so, we've been utilizing it more frequently now. But it's important to find out when it is useful. So when somebody has Parkinsonism, like stiffness, slowness, and tremor, and it appears to be neurodegenerative, it was much less 3 years ago and now it's more. So you already know that there's a neurodegenerative Parkinsonian disorder going on. when I would utilize a DAT scan in those situations, it could be typical or atypical, because it does not help us distinguish between typical or atypical Parkinsonian disorders. So I would not use it to differentiate between typical and atypical. The only times I use it is if, number one, somebody says, okay, I don't believe what you're telling me, I don't think I have Parkinson's disease, or I don't think this is what's going on. I want some objective evidence, and if I have something going on. So to prove to the patient that this is likely and like a neurodegenerative primary Parkinsonian disorder like PSP, MSA, DLB, these conditions, that's one of the reasons. The other reasons is somebody has Parkinsonism, they have a huge history of psychiatric illness, and they have been on dopamine blocking medications, and now I'm sort of, the patient is worse. Okay, is it Parkinson's disease or is it medication-induced Parkinsonism? The DAT scan is negative in patients who have a drug-induced Parkinsonism, and a positive in all the primary neurodegenerative Parkinsonian disorders. The last one is when somebody has a tremor going on, and we were discussing this a minute ago. Is it essential tremor? And we know that people who have long-standing essential tremor can actually develop Parkinsonism after decades. So is it Parkinsonism because they now also have Parkinson's disease, which is not uncommon? Or is it because it's just essential tremor, and now they have Parkinsonism from the essential tremor? Sometimes I get a DAT scan to make sure that it's not one of the other. And in essential tremor, it will be normal. If they have essential tremor and now they also have Parkinson's disease, it will be positive. Having said that, we know that in MSA and in some patients with PSP, the DAT scan may actually be normal in some of them.
Next question.
Yeah, my question is for Dr. Clater. Sensory nerve conductions are generally known to be normal in lumbar radiculopathy. But if somebody has chronic, severe, multi-level lumbar stenosis and known radiculopathy, can you see absence of sensory nerve conductions even in their 50s?
The one notable exception to that rule of sensory nerve conduction studies being normal in radiculopathy is when you have an L5 radiculopathy. So about 20% of the population has their sensory ganglion that's actually intraspinal. And so for about 20% of people, sometimes you can see changes on the superficial perineal sensory response, especially if it's a severe L5 level radiculopathy. So that's kind of the one notable exception to that rule.
Okay.
But their sural sensory response should be normal. Just the superficial perineal should be affected.
So, Dileep, I have a question for you, and that is that somebody asked that if somebody's seizure-free, but they have some generalized EEG pattern on their EEG, what do you tell them about driving? They have epileptiform discharges.
Yeah, so driving is related to the report of seizures. So if you, now, by the state, so it's based purely clinical interpretation. Now, in a patient with generalized epilepsy, however, there's a concern about understanding the severity of illness, for instance, the absence seizures. Patients are typically great at knowing whether or not they've had a convulsive seizure. Absence seizures are harder for them. And in that situation, when I do see bursts of EEG that are lasting significant periods of time, 10 seconds or longer, then I do I'm restricting the driving situation in those patients. The occurrence of a single discharge lasting less than a second by themselves, and that's the only thing that I'm seeing, I will not use that as a way for that. Just basically tells us that he or she has epilepsy.
Right.
It doesn't mean necessarily that they're having disabling seizures. So that's the question: are they or not having disabling seizures in terms of driving? And in focal epilepsy, you really can't. It's harder to sort of sample the EEG with the expectation that you're going to see a seizure on an EEG at that stage. In patients whom I'm suspect in relation to their ability to report, I might sometimes use an ambulatory EEG to understand whether or not they're having unrecognized or clear clinical seizures.
Craig, do we have the questions? Sorry, we're going to go through the questions here. So first one is, what is the generator of the scalp recorded EEG signal. A, action potentials from cortical neurons. B, action potentials from thalamic neurons. C, synaptic potentials from cortical neurons. D, synaptic potentials from thalamic neurons. So I can see the answers come up. I'll probably pop up here in a minute. And it looks like everybody's favoring answer number C, which is the correct answer. As Dr. Nair had mentioned earlier, you know, the action potentials are too small to be seen in the scalp recording.
That's right, yeah. And the synaptic potentials are longer lasting. They are involving the apical portions of the dendrites layer 2 and 3. And so they're really perfectly organized anatomically to generate EEG signals.
Okay. And he showed an example of this. Hyperventilation as a provocative maneuver during EEG is contraindicated when, so when should you not use it? Sickle cell anemia, hypoglycemia, hyperglycemia, temporal lobe epilepsy. It looks like you guys are paying attention. So the vast majority have answered A, which was the correct answer.
That's right, yeah. Hyperventilation can cause vasoconstriction, and in patients with cerebrovascular disorders, they should not be performed. Hypoglycemia can accentuate the, both hyper and hyperglycemia, but particularly hypoglycemia can accentuate the normal slowing seen on hyperventilation. And although temporal lobe epilepsy is unlikely to be diagnosed with HV, it's not contraindicated.
Yeah. Remember, you change your CO2 levels, causing the risk of the. I'm moving. No. There we go. Oop. Was that it for all those? I think he's going to throw the other one up here. And then we'll go to break, and they'll be around, so if you have questions. So Ben, these would be your questions. Sensory nerve action potentials would be normal with which of the following? This is always an important question. Lumbosacral plexopathy, cervical radiculopathy, sensory ganglionopathy, median mononeuropathy at the wrist, i.e. carpal tunnel. And again, it looks like people are paying attention. So the vast majority feel that it's with the cervical, and he showed the nice picture of where the lesion is relative to the dorsal root ganglion. Question number 2, which of the findings on motor nerve conduction studies is consistent with a primary demyelinating neuropathy? A 50% amplitude reduction, conduction velocity that is 90% of the lower limit of normal, a 15% conduction block between distal and proximal sites, motor distal latency prolongation greater than 50% of the upper limit of normal. Moving to a consensus here. So the majority of people felt that D was the correct answer, which it is. So motor distal latency prolongation of greater than 50%. Very good. And then I think we have the movement disorders. So we'll answer those two, then we'll move to a break. So the Parkinson's disease questions. Parkinsonism means any of the following features: tremor, apraxia, alien limb phenomena. B, rigidity, bradykinesia, tremor, and eye movement abnormalities. C, rigidity, bradykinesia, postural instability, and tremor. D, spasticity, constipation, REM sleep behavior disorder. Well, I don't think I've ever seen this happen before, but it looks like, I thought for a second it said 103% there. Whoop. So I think we had pretty good consensus there. And the final one, a 73-year-old man with a 1-year history of shuffling and slowing down, now reports seeing shadows out of the corners of his eyes and has been having fluctuating sleepiness and confusion and worsening balance. Sounds a lot like me. Continues to report a response to levodopa. He likely has PSP, CBD, MSA, DLB. Well, you guys are very excited. Again, there's a lot of consensus in the movement disorders group, and you are correct. All right, so thank you very much, gentlemen, and we'll take a break. They'll be around to ask questions. We'll come back for the very last session on neuroimaging. We'll do brain and spine, multiple cases. Thank you, gentlemen.